Rakesh is one of the laryngologists from Lucknow, India, and he travels around the world, gives a wonderful talk. I think it's all yours about for next. We might be running 5-10 minutes. Apologies for the panelists for the final session. Thank you. Rakesh, you can start. Yeah. Are you talking or? We can't hear you. Yeah, I can.
I'm audible?
Yes, you're audible now. Yeah, talk. Yeah.
Yeah. Thank you, Dr. Jay, Dr. Sam, for inviting me to give a talk on subglottic stenosis. I'm a consultant laryngologist practicing for airway surgery for past 15 years now. And my talk will be centered around subglottic stenosis, different because I am coming from a different part of the world, and I'll be interacting and giving my opinion on the frugal innovations, how we manage it in limited resources, and current medical and surgical management of subglottic stenosis. No disclosures. So subglottic region is defined as a space extending from 1 centimeter below the lateral margin of the ventricle to the inferior border of the cricoid cartilage. So as we go along, the causes of adult laryngotracheal stenosis, iatrogenic comes the first. Autoimmune and traumatic, idiopathic are almost the same percentage of cases. In autoimmune cases, in our region, we don't see so much of idiopathic progressive subglottic stenosis, but we see other causes which are related to inflammatory or infective causes of subglottic stenosis. So comorbidity index was associated with the 67% increase in odds of tracheostomy dependence. And these things we will be covering later in my talk. What are the factors which are affecting it? So this is one of the case which was very old, I think recording almost 10 to 12 years old. And these types of cases we get the patient on spontaneously breathing and coming with a respiratory distress in emergency ward. And then we see the patient in OR and then decide about the. So one of the commonest causes is iatrogenic related to intubation or related to tracheostomy. So one is tracheostomy related, we see with the procedure related problem, and other things we see a lot of cases of poor care like suprastromal granulations, complication due to fenestra in tracheostomy tube, either company made fenestra or it is created by the resident doctor to let the patient speak through the fenestra, and that lead into the granulation tissue formation and later restenosis. PCT related, percutaneous tracheostomy related like fracture tracheal rings, and then high tracheostomy. We are seeing a lot of cases of high tracheostomy, the tracheostomy done in the periphery of any district level hospital where there is no proper care is there, and we are seeing a lot of cases related to high tracheostomy. So I'll be sharing my thoughts on it. So sometimes we get cases like this with this type of finding. This is a case of a clothesline injury. So clothesline mid neck level injury usually present in a different picture. Sometimes they present it very early, or sometimes they present 10 to 14 days after the injury. So sometimes you will see cases like this, patient sitting in your outpatient department with with the endotracheal tube in place. And sometimes we see these type of cases after 15 or 16 days of injury, like tracheal diverticulum. There is no emphysema, subcutaneous emphysema, and patient has a one trachea which is going like a normal, and there's a diverticulum outside one. And sometimes we see cases like this, patient with a double trouble presenting like a bilateral fixed cord. And then we see the subglottis, there is subglottic stenosis also there. And there is a posterior glottic stenosis. And there is a multi-level stenosis, which is not significant, but it is associated with post-intubation stenosis. So proper assessment under general anesthesia is important to see below the cords, so look for the double lesions. Sometimes we see a picture like this with PCT done, percutaneous tracheostomy, and there's a fractured lower border cricoid with the injury to the posterior tracheal wall. And there is a bulb pressure is also there. So that is also causing this type of stenosis. In the previous talk, these things have already been covered, like iatrogenic airway injury, pathophysiology, and how the stenosis progress in patient of iatrogenic, that is post-intubation. So 4 hours of intubation causes some damage to the mucosa, capillary blood flow, and if the pressure is high, above 37 millimeter of mercury, that also causes leading into the decreased capillary perfusion, leading into ulceration and later into the stenosis. So sometime after long surgery like bilateral total knee replacement, we see sometimes like this type of picture. After 1 or 2 days, patient complaining of uh, slight difficulty in breathing. So phases of airway mucosal healing is hemostasis, proliferative phase in 3 to 10 days, and there is a remodeling phase where the collagen formation is there and it is replaced by the type 1 collagen, which is stronger and causes scar formation. Fibroblasts in subglottic scar are phenotypically distinct from those in normal airway mucosa. So the characteristic of some mucosa and some mucosa in subglottic area is different, and it gives a different picture. And similarly, the polyangiitis also arises from subglottis, and we see cases of GPA also in our area. But idiopathic progressive, we hardly see 1 or 2 cases in a year. That is not very common. So disease prediction for subglottic is basically because of the narrowing of upper airway at the level of cricoid ring. There's a turbulent airflow, exposure to upper airway gastric acid, and susceptibility of ischemia at the watershed area, which causes this. So now I'm coming to the interesting part of it, that is high tracheostomy, which we are seeing it very often. And this, the video on the right side, if you see this patient has a post-radiated with a fixed vocal cord. I'll play it again. This on the left side. This is a classical high tracheostomy and patient presenting delayed with granuloma formation, granulation tissue there. And this patient has a bilateral fixed cord because of the radiation. And this is again an interesting case. Patient is seen on 26th of Feb this year only with uncontrolled diabetes, with a high tracheostomy. And what I did is I reduced the size of the tracheostomy, tried to control the uh, sugar with the endocrinology reference. And then we followed this patient after. So this was on 26 Feb, and then this is on followed up or after 1 month. This patient has settled down. The inflammation has settled down, and this has patient is managed conservatively by controlling the sugar and downsizing the tube. Idiopathic progressive subclottic stenosis we hardly see in our area, but the incidence is slightly variable. We don't have any article to support what is a the situation or the incidence and prevalence of this disease in our Southeast Asia region. But it is quite common in Canada, one of the area where the incidence is very high, 9.3 per 1 lakh of population in that area. And it is mostly seen in Caucasian perimenopausal women. The other interesting cases what we see is this is a post-tubercular fixed vocal cord with subglottic stenosis. And this was peroperative. Patient presented with difficulty in breathing, and so we did the balloon first and try to reduce the subglottic edema. And then later, because the cord was fixed, then I did his posterior cordotomy, and then after that again did the balloon, give Canalog and mitomycin C. So neck injuries are also very common in our area because of, especially in winter seasons, we see a lot of injury because of the neck scarf or because of the kite flying. The manja injury is there in the mid neck region. So mid cricotracheal injury is common. We see complex injuries. This is again my presentation on post-tubercular upper airway stenosis, where you will see the lot of spectrum of disease from supraglottic, glottic, subglottic stenosis. So we have few cases of subglottic stenosis because of post-tubercular. The history of tuberculosis is there, and because of that, the patient presented with this type of picture. Post-radiation cases also we see supraglottic and glottic stenosis and subglottic stenosis. This is my presentation and it was published also. Now coming to the assessment part, which I think what missed out, I think, in the presentations is we normally do the subjective test using Modified Medical Research Council dyspnea scale. And this is a very good scale for assessing patient follow-up also, not only for pre-surgical assessment, but for follow-up also we use the same method to keep the patient on follow-up because we get patient from far off distance from other states also. And before the surgery, another frugal innovation we do is we use this device. This is spirometry. This is US FDA certified company Fit, and we use it for pre-operative assessment, and the parameters are almost equal to the what classical spirometry we do. And the other way is physically we do with this type of spirometry at home. And these type of video patient used to do it and share it on follow. Pre-operative also we do it, and post-operative also we follow this patient on. The other armamentarium which we use it very often in our practice is high flow for assessing patient, even for the surgical management if you are doing it a endoscopic management. Manujet, with the invent of high flow, we almost stopped using Manujet. Initially, we used to do it. Otherwise, we use the other methods of using local anesthetic agents and infiltration to block superior laryngeal block, transtracheal blocks, and glossopharyngeal blocks. I use is my specially designed Klensaucer laryngoscope with 6 holes in the back, 2 on the sides. This laryngoscope, I have published it in my the Laryngology and Voice Journal. And this, I use it for high flow surgery if I'm doing an endoscopic airway procedure, because this maintains the oxygen flow in the glottis. If I put the laryngoscope and block the glottis, so we can continue to use it. Not going into the detail of how the fiber optic is done in all airway cases. So we do not attempt any in the office in case of severe stenosis. Archiving is must in all cases. Normally, we follow this type of algorithm, which is we share it with the Lausanne, and this is an endoscopic assessment scale is there from vocal fold mobility to OSA, then congenital LTS, acquired LTS, we know it. The grade of stenosis already been discussed so many times. Craniocaudal extent of the stenosis, we mentioned it in office. And the same thing we follow for pre-operative and post-operative also. Grade of stenosis, site of stenosis, posteglottic stenosis already been discussed by Professor Karagama. Then regarding the glottic web, same scoring system we use it. But we have some modification with cotton mass, which follow we usually the Professor Munir scale on site specific. That is 4 site specific, 1 site specific, 2 site specific. And we consider comorbidity is a very important part of it, especially the neurological patient and obesity. One of the important factors we consider it for managing this patient. So, severity of comorbidities, this already been discussed in previous lectures, like MRSA, especially if we are doing open reconstruction, then neurological status of the patient, GERD and LPRD is important component of it, and obesity is, of course, the most important part. Aim of the treatment to have a decannulation of the patient and to have a good procedures. So these are the various procedures already been discussed by previous speakers. I'm not going into the detail of it. I'll just share what is my experience into it. When to do endoscopic, when not to do endoscopic. This is also controversial. The failed 3 endoscopic treatment in a year, we go for an open procedure. These are the factors which already been discussed by the previous speakers, like how you mention in your per-operative record the status of it. Now, one of the main component of my practice is intralesional steroids. So this was a complex case, which I am playing is a case of a clothesline injury. And if you see the serial recording of this patient undergone 5, and this patient was having a bilateral recurrent laryngeal injury also because of the clothesline injury, the bilateral cord paralyzed. So these are in-office procedure. On the left side, this patient was having exposed cricoid cartilage, where we did the mucosal graft, buccal mucosal graft and stenting. But granulation tissue reappearing, and it almost took almost 1 year to settle this patient and have a complete decannulation of that patient. So Silsi, the serial intralesional injection is quite effective. And this has been by a systemic review study on 187 abstract and 4 were included into it. On 55 cases, it has been found that surgery-free interval has increased by using this intralesional steroids. For a non-tracheostomized patient, what we do is we give a oral spray, then transtracheal block, then we give a infusion pump of dexmedetomidine with the propofol, use a high flow, superior laryngeal block, and then we go ahead with the endoscopic procedure. So this is the algorithm for endoscopic management: assessment of airway, release of stenosis, balloon tracheoplasty, injection canacort or canalog, topical mitomycin C, and downsizing of tracheostomy tube if patient is on tracheostomy. This is a tool which now for past 2 to 3 years I have been using, that is a coagulation, which is quite effective for a soft stenosis. And downsizing the tube is one of the best way to have a good mucosalization of the proximal airway. These type of video already been shared. The subglottic stenosis using a CO2 laser, using all four quadrant, then using a balloon, the same protocol, and this all surgery without the tube anesthesia. This is a follow of that same patient. This is a sequelae of healing in these patients. Sometimes we have a like that type of healing. So coming to the procedure which has come from the UK, the Mandarin procedure, which is introduced by Dr. Guri, and he gave a 5-year study, first paper on 9 idiopathic progressive subglottic stenosis patient. 2 patients required unplanned tracheostomy with a median for of 2 patients required a laser procedure after the primary surgery. So what is the membrane? You all must be knowing it. There's a radial cuts we give. The intermittent mucosa is curated out by the debrider, and the split thickness skin graft is used to give it. The stent was removed, and so there are role of various tools. I am now use a coblation also only for soft stenosis, but otherwise my choice is always a CO2 laser as a workhorse for laryngeal surgery. Post-operative also, we do early nebulization for all cases, first 2 nebulization by Adeline for endoscopic procedures. Doses are different. For pediatric, we use is a zero point 0.1 mg per kg body weight, that is almost 1/3 of an ampule of Adeline. For adult, we use up to 2 or 3 ampule of Adeline for adult patients. And this I have already covered. The follow-up patient we use is a hypernip combined with a ciprofloxacin ear drop with a dexamethasone dilution, 1.5 ml of Ciplox D, the ciprofloxacin dexamethasone drop with 3 ml of hypernip. Antibiotics and other things are almost the same. Reflux medication is important for all patient preoperative and also postoperative management. So follow-up I usually do is 10 to 14 days and 21 days, 6 weeks and 12 weeks in most of my patients. Otherwise, because of the distance, sometimes I do a video consultation just using this dyspnea scoring system. And so window period is usually 2 to 4 weeks, which I think is the most important part when the patient comes back again with the respiratory distress. And for that period, we keep a close watch on these patients. Coming to the open surgical approaches, the preparation is almost the same except for we do feast test and look for the esophagus for eosinophilic esophagitis. Airway colonization is must because of poor tracheostomy care in our subcontinent, and we send the whole of the tracheostomy tube for culture and sensitivity. 5 days of antibiotics prior to the surgery we give. Normally open reconstruction we start with vancomycin. For high tracheostomy we use is a patch tracheoplasty. Uh, for that we use a higher, sometimes we use is a thyroid cartilage, upper part, the LR cartilage, what we use for the pediatric airway. And sometimes we use is a conchal cartilage also for repairing anterior part for high tracheostomy patients. So this is a case of high tracheostomy. This is the same recording of the same patient where we did the patch tracheoplasty. So it is very high, almost at the level of cord. This is another case of the same method like what we use for pediatric airway, that is using a LR cartilage and repairing it for defect. Now coming to the other open surgical procedure, what we use for subglottic stenosis, LTR, which is less invasive. So normally in LTR, we use it only for the mild grade of stenosis and use uses costal cartilage graft, and it is good for it because it preserves the voice, but it's mostly required a double stage procedure, and it has got a more failure as compared to the partial cricotactal dissection as compared to the technique is the same. Normally, we use is a PDS sutures for anterior repair. Now, this is more study. Take all the suture one by one, then we parachute the whole the graft like that. And for the posterior repair, we use the same costal cartilage graft. And for the PCTR, for effective for high-grade stenosis, that is partial cricotracheal resection, fewer stages needs a complete compared to LTR. Complication with the PCTR, sometimes we have an osmotic dehiscence or granulation tissue formation. For posterior repair, we use a vicral suture. For anterior repair, we use is a PDS sutures. And that also depend on the age of the patient because I am doing both the adult and the pediatric airway. So the, the size matters according to the age of the patient. Now coming to the CTR, it has got a higher decannulation success even in grade 4. It is one stage procedure, remove the disease segment completely. But it is technically more demanding because there are chances that patient will have a problem in the voice, not only related to the recurrent laryngeal nerve injury because of the related to the injury to the cricothyroid muscle itself. So patient might be having some problem related to high pitched singing or high pitched voice. Airway stenting, we do it very often because in our context, we have a problem of the cost. So many times we have unavailability of the ICU beds because of high load of airway patients and other patients in ICU. Good ICU care is sometimes not available. So for complex stenosis, for long length stenosis, failed reconstruction, and when there is a stenosis which is close to the vocal cords, there are other systemic factors like patient have a neurological poor neurological status, poor cough is there. So those patients we have to be very selective in doing it, and we use normally the stent, either endoluminal stent or we use a tracheal T tube for maintaining a airway. So various modification which we evolved in last 15 to 20 years. This is one of the older one of Abulkar stent. Then we modified it to cutting a T tube. Then this is another way of using a ruche nasopharyngeal airway, which is very soft silicone material and is least reactive. And I'm finding it very good for when we have the problem of cost. We have to see over the because we now we get a rudder stents and other stents also silicone based, and sometimes we use as a Montgomery T tubes and modified Montgomery also we use it. Stent itself has its own problem like certain obstruction, granulation tissue, and microbial colonization. So, but normally we try to remove it within 6 weeks. 3 to 6 weeks is the normal average time we'd use it. Biodegradable stent are the futures. We are not using it, but PDS, we have started using it for repairing the anterior wall. Now, coming to the adjuvant medical treatment, I'll just in brief. So, the potential what we see in a future, this thing is perfenadione, that is, and sirolimus, that is drug-eluting stents. Now it has been used in murine model now, though it has not been used in human, but it has a potential to use it. Perfenadione, we have started a study in our center and the one center in Delhi. So we'll be coming up in 1 year time that how's the road of Pirfenidone because it's an antifibrotic agent which is effective against TNF alpha, TNF alpha, and also in interferon, the this prostaglandin also. So antibiotics we normally start with the vancomycin 1 or 2 days before the surgery, continue for next 5 days, and then we later on shift to other simpler antibiotics. Mitomycin C, we use it, but there is no lack of standardized protocol for its use, duration, administration frequency, but we are using it for all endoscopic procedures. So Perfenadione has a important role, I think, in future, and maybe in 1 year time we'll come up with a controlled study with uh, using Perfenadione as an isolated agent. Sirolimus eluting airway stent, again showing a very good potential for it, and it will come shortly in human use also. Now coming to the conclusion, I just will highlight is regional and population-wise variation of subglottic stenosis is there. We don't see so much of IPSS. Disease trend is changing, tracheostomy and its related complication increasing. The intubation-related incidence is coming down in past 15 to 20 years in our subcontinent because of the good Portex tubes, and anesthetists are now aware of it. The intensivists are aware of it. The care in ICU is improving. Clothesline injury is still a problem. It's a different ball game because of so many neurological issues associated with the clothesline injury. Endoscopic management, more tools are now available. Mandarin procedure, another potential, though I have not used it, but maybe in future cases I will think of using the Mandarin procedure. Biodegradable stent, drug-eluting stent are like sirolimus stents, are potential, Perfenadione and other antifibrotic agents. Follow monitoring using various Bluetooth-enabled spirometry devices, and you be using various scoring system will be quite helpful in managing these patients. With this, I just concluded where they say that if you fail, never give up because of fail means first learning, and is not the end, it is the end means effort never dies. If you get no as an answer, remember no is a means next opportunity. So in airway, we do it, we never lose our patience, and we treat the patient like every stenosis is unique stenosis, and we have to treat the patient like a not only the stenosis, but treat as a patient. And as a family members, we take care of it so that all whatever failure will be there, it will be managed by our team and my team only. Thank you very much.
Thank you, Rakesh. That's a wonderful talk with loads of experience, very honest, transparent, and open discussion. I'm grateful for your talk, and there's a lot of innovation as well. But innovation doesn't mean always expensive.